press more of the anterior horn here. And do you remember the end feel in patients that have meniscal pathology? Springy block. So a lot of times these folks won't have full extension. Okay? And so what you do is support the limb and put a hand behind the knee to support it and gently let gravity take them down. Okay? I'm not taking them up here and slamming them to the table. I'm gently holding the knee and I'm just letting, just a few degrees, letting gravity. And if they have a meniscal tear, what you might see is they'll pop down, they'll have pain, and they'll bounce back up. We call this the bounce home test, or the bounce home maneuver. Okay? What I'd like you to do is just take your patient's knee and just gently get them to relax and just take them up and let them fall into passive extension. And a positive finding would be pain and a rapid flexion. And you might even have a springy block here as you take them into full extension, so be aware of that. That's the bounce home maneuver. McMurray's bounce home, and I think Paul Steinman's point tenderness test. This has actually got pretty good psychometrics from the few studies that have been done. Let's think about the biomechanics again of the meniscus. They follow the course or the path of the tibia, correct? So let's say that we have someone, we've done our history, our exam, we have some signs and symptoms that lead us to a meniscal tear. How important is joint line tenderness in your exam for meniscal pathology? Pretty important. It's a pretty good clinical finding, okay? So what's interesting with Steinman's, if you get them in a certain point of knee flexion, and let's say I palpate in the joint line, and that's tender, okay? And I take him out, and I stay on that point, I take him out into more extension, and I palpate that exact same spot, and that's not quite as tender. But if I move a little more anterior, and now it's tender, do you see how the moving point tenderness changed relative to the meniscus and the knee joint position? So I take him out even more, and I palpated that same spot, and it's not tender there, but I move anterior yet, and there it's tender. That's a positive finding. That's Steinman's moving point tenderness test. Now, let's take it the other way. Let's say that I'm palpating the anterior joint line here, and I flex him up, and now it's not tender in that same spot, but now I move more posterior, and there's the tenderness. I flex him up some more, and then I follow that. Now it's even more posterior. Okay? That's Steinman's point tenderness test, moving point tenderness. Any questions about that? So you're following the meniscus as it moves with different positions of knee flexion. Any questions about that? It's pretty straightforward. That's easy. Comments on that at all? What about Apley's, Paul? Are we going to show Apley's? Okay. I'm going to show you this because you'll probably get out in the clinic, and this is one that you'll see a lot. So let's go ahead and put you on your stomach. This is Apley's compression and distraction. Okay? So what we're going to do is, again, we're going to take the knee up into flexion. And what I'm going to do is laterally rotate, and I'm also going to compress and palpate at the joint line. And what I'm trying to do is capture or trap a torn meniscus here. This is Apley's compression. Okay? So medial meniscus, I'm on the medial joint line. I'm compressing through the tibia, and with my other hand, I'm palpating at the joint line, and I'm just compressing and rotating the tibia. All right, and you can try a different angle of flexion. All right, and that may elicit a positive finding. Jimmy? What were you palpating at the joint line again? Remember, meniscal pathology. No, just the medial joint line here. And then we can do the same thing for the lateral joint line. We'll just walk over to the lateral joint line, and we can medially rotate and compress. and see if that doesn't elicit any symptoms. That's Apley's compression. Now, Apley also described a distraction test, okay? Similar, except the difference now, instead of compressing the joint, I'm going to lift up on the tibia. And sometimes you might see a clinician put their thigh up here and hold them down, distract, and now I'm going to rotate and do the same thing at the joint line. And that's Apley's distraction. Apley's distraction, Apley's compression. Dr. Lummer?
The Apley's is pretty specific as well.
Is it?
80%. But what's interesting is the joint line tenderness is 85% sensitive. So as far as the sensitive test, that's one.
Yep. So again, here's a case where knowing these tests, you cluster them. And if you find one that's real specific and one that's sensitive, it just gives you more clout, or it helps in your decision making when you're talking about, diagnostics. Okay? Other meniscal tests, was that all we needed to do? Think?
There's one that's talked about or discussed a lot, and that's